Visit University Hospital. I am cardiologist, and in my center, almost okay, I do TIVA and EVA in the cat room. And today, I'm very happy good to see to sharing with you about some experiment and diagnosis and treatment of endovascular for the B type in the single center in my center. Could you hear clearly?
Yes, yes, nice to meet you.
Okay, nice to meet you. And we can start now.
Yes.
This is my hospital and my presentation, and I hope that you can enjoy it. And this is my Philips University Hospital. It's the oldest modern hospital in Hanoi, in Vietnam. And in my center and in my hospital focused on the surgical activity. And my center is the oldest center of the cardiovascular and thoracic surgery in Vietnam. And I have just come back from to CPC in the China last year about for the China Vascular Congress. And now today we talk about blunt trauma aortic injury. All of you know about the life-threatening surgical emergency. Maybe 85% die at the scene, and survival maybe 30% die in the 6 hour, and 49% die in the 24 hour. Is the non-treatment. And in the picture, you can see that this is my patient. You can see this is a very polytrauma. We transfer another hospital to my hospital with the B-type type 3 and very severe in the lung and the liver and the kidney, and with the trauma in the head, and we treat with the B-type. We can see it's a B-type now. And etiology of B-type, almost see is the machine of the B-type, and sometimes over okay we see the lesion all the way in the smooth, we see that's why we call the maybe 70 and 90%. And classical of the B-type for grade 1, for grade 4, and grade 1 intimal tear is this special almost okay in my center all the way try in the medical treatment. And grade 2 and grade intermembrane hematome always follow up carefully. If you have a high risk patient, treat endo by. If not high risk, maybe the medical treatment. And grade 3 and grade 4 all the way to emergency treatment with the TIVA or operation. And we have to some compare with the operative repair with the TIVA. And in the part, in the same in the world, in my center, always choose for the open repair for this patient with the B-type. But 50 years later, always we choose the TIVA because a lot of the effective and quality for treatment with B-type with TIVA. And you can see almost the case mortality with treatment with the TIVA all the way lower with the operation. And there's some complication like the peripheral line or the renal failure all the way later than operation. And with the American Association of Surgery of Trauma, we have a choice of treatment. We try always subject to endovascular repair, perform overall the open surgical repair. And in my center, in the part, we always do discuss about the timing of the TIVA in the stable patient. With the stable patient, sometimes we have the grade 3 or grade 4, grade 3 come in my hospital. Maybe in the part we try emergency to do the TIVA, but now we always try to later after 24 hours in the stable patient, because we will see that in the stable patient when you treat the TIVA after 24 hours, maybe the mortality lower with the significant than within the 24 hours. And for the type 1 management of aortic injury, we subject all the way to treatment by medical treatment and follow up. At least 1 week later, we treat again for CT scan. If the patient is okay, we can discharge, and if not okay, maybe improve or something. Try to the tip 2 or tip 3, maybe try tip 1. And in the young patient in the LSA zone 2, in my center, in the past, sometimes you choose for the emergency. Okay, I choose to the cover this LSA, but the time now try all the way to try to the revascularization all okay. The left subclavian LSA for the older patient. And systematic heparin, you know that sometimes you do the EVA or TIVA all the way we forget to put the heparin loading door. But for this patient, you have a lot of polytrauma and high risk of bleeding. That's why sometimes in my center we divide 2 groups. One group is not high risk for bleeding. Maybe you do the heparin normally, but in the high risk, in the group high risk bleeding, sometimes I use the hard dose, or sometimes you don't use the heparin because scare about, especially in the patient with trauma in the heart, in the abdominal, for example, like a sprain liver. And spinal drag we don't forget routine the spinal drag in my center. And we try to use the general anesthesia because very easy to control and to keep care of this patient. Because sometimes this patient you have to head trauma, you have unconscious, very difficult. You can control the hypertension or the patient in the volume. And this is my experience from my center, Physics Center University, data from to the May 2030 to September 2022. We had 15 patients with the p-type, and almost okay is the male, the males, maybe around 38 years old. Almost okay the emergency 1%, 100% K or check CT scan before the intervention. And every time for the onset to the intervention, maybe 20 hours. Almost okay, we had the body or organ injury, and we had the 20% patient we had a stroke in the p-time. And you can see that almost okay, grade classification is grade 3, almost maybe around 76%, and low patient always or sometimes is smooth as the 1K ascending time for the operation. And for the eye, we had to 24%, and that's in down we had to 16%. And we had the 29K of Chiva cover LSA without the evacuation. It's a past, but now we are almost okay. We try to evacuation every time, especially in the high risk patient. We had 4K of Chiva, we had penetration for the LSA. Once I use the homemade stent graft technique because the very small our tick, because in Vietnam sometimes you have to not enough the stock for the stent graft, especially in the measuring. I use the reverse the limb for the element 2 with the cup to cover this lesion because the patient is very young. And 4K you have the femoral access trouble. 1K we have the bypass. 2K you have the angioplasty by balloon only, and 1 condi bypass for the iliac artery. We have the 5K I use only to the non-man stent graft from the variant measuring, and 2K for the limb. 1K zone 1, 2K for zone 2, and I had the 4K always using the rapid fixing because I try to reduce the hypertension. A very good time to when we release the stent. And we had the 15K hybrid module, and for 4K for the ice outer, 1K AU rebound technique for the arctic balloon control because it's patient you have to the trauma with the TABC, and 6K triangulation of the LSA. And this is my experience, general anesthesia, where I had the 52%, and local anesthesia 48%, and heparin in the patient always try to 0 or half dose, not loading dose because high risk of the bleeding. We have the complication, low blood pressure, low cellular ischemia, and low embolic. And we had the 3K death from the 30 days because one case by the septic shock for the multi-oral injury, and one case by the peritonitis for the second day, and one case rupture before the operation and intervention. And follow up 8 years later in low complication at that time now. And I have to see that some case. Yes, see the case. I do the hybrid produce carotid bypass, LSI transplantation, and put the TIVA for zone 1 with the variant metric, non-bad. Because sometimes very carefully the migration of the stent. That's why I use the repeat patient to reduce the hypertension and very control the right portion of the stent graft. Another case, we have the total supra to the vascular aortic, and after that, you will see that very total and very angle. This aortic act because very young patient, and because very small iliac, that's why I use the conduit to put the stent device inside and put the stent all the way. I release the stent with the repeat patient. And another case, we have TIVA recover LSA with variant non-bad. ICO is in the curve technique. That's why when I release the stent, I try to always release from the inner curve first because careful about the butt. After the stent open and dropping in the inner curve, I try to release fixing carefully and rapid release on the stent. Like this. Sorry, maybe I have a problem because some video maybe heavy. Okay, sometimes we have the aortic trauma with the B-type at the same time with the B-type. I try to push the balloon from to the metric, control the proximal line the cross intra-cross in the aortic, and try to the open repair to bypass from to the ascending aorta to the TAPC. After that, we put a stent for the B-type. In my center now, I own one of I do to the open to penetration for the LSA. Is it some case I do the penetration in vitro on table for the zone 2? You can see that to make a hole and like this, and always cover and not cover and make a penetration as a evacuation for the LSA and blood supply for the LSA input and patent. And sometimes you use some emergency case. I try to cover, and after that you use the little balloon to make the hole like this. This is a device from the lighting company. I try to puncture. After that, you use the V18 do the penetration, you use the balloon dilate, and I put the stent inside. Because there's some case, emergency case, it's not stable patient. Sometimes I try to put the stent immediately, and after that, when everything is stable, I make the stent patient to the revascularization for the LSA. And conclusion, I think rest one in my center always try to medical treatment and follow up. And grade 2 almost okay optimal medical treatment, but sometimes high risk patient carefully. We check again to CT scan after 5 or 7 days. If the head to patient improve is okay, but distrust patient is not, maybe try to put the TIVA. And grade 3 and grade 4 over TIVA maybe more than favor than open repair. So timing of TIVA of stable patient maybe more than 24 hours. And in my center, this patient in high risk bleeding, I always try to use the half dose or zero heparin for the TIVA. And midterm is good, but this more data for the long-term result. And thank you for the attention.
Thank you for your nice sharing. And we don't have that many lung trauma cases, but I think most of our cases is around isthmus level or distal descending a distal aortic arch. And so for most of our case, we regularly do zone 2 T-bar or zone 3 T-bar. We don't have that many proximal case.
Yes, because in Vietnam, a lot of the traffic jam. That's why in my center, a lot of the server trauma in the north of Vietnam transfer all the patient from my hospital. That's why in my hospital, the maybe I think it's the luckiest the patient from the B-type in the north of Vietnam.
How about chimney technique? Do you use that?
For the chimney?
Yeah, for chimney technique for maybe zone 0, zone 1, zone 2.
Sometimes I do the chimney because almost of the patient always young patient, and I always care about for embolic because for a lot of the report says that when you follow up after the chimney, you have to enter and maybe to have a high risk of the embolic type 1 for the later. Either for me, chimney always for maybe benign technique or sometimes for the high risk patient. And this patient is okay, maybe I will operating for the hybrid technique or sometimes you use penetration. Because in my center, I can do the penetration by the needle device or on table, or sometimes I do penetration by to the guide wire or to electric guide wire. And that's other time now, almost okay I do by endo, not to chim. I think each chimney is a follow up is not good.
Oh yes. So when you will decide to revascularize the subclavian artery?
I start to penetration for the LSA from to the 2019 in the first case. I think it's the first case in Vietnam too. Other time now we had total for the penetration for the LSA. We had the 64K, almost of the needle device balloon in the penetration on table or electric guide wire. And this year I tried the first case use a laser device. It had available in Vietnam now.
I have one question. What size of the T-bar you decide to perform T-bar for prompt out injury? The maximum diameter of stent graft for out injury.
Could you repeat the question and maybe you can speak louder because sometimes we have the problem with the internet. That's why I hear it's not good.
That's why sorry, I ask one question. When you decide to perform T-bar or prompt out injury, the stent graft diameter what locator do you decide to perform T-bar?
For
the T-bar size, stent graft size.
Stent graft size. The same. I think the same. Almost okay. I do the stent graft size. I choose maybe around for the 0 to the 10% oversize. But sometimes some case because I don't have enough the sizing in the stock from the measuring in Vietnam. Or some case of the cook or from the Bolton. That's why some case I oversizing more maybe 24 20 or some case 30% because this patient sometimes very young and the aortic diameter very small and sometimes I oversizing bigger. But because you know that almost okay with the B-type because the proximal and distal may be healthy, and that's why you can choose at the same with the energy maybe oversizing bigger, not like acute dissection.
I have one more question. How about the grade one patient? You choose regular follow up, right?
Right.
Yeah. How about the follow up condition? Because in Taiwan, most surgeons still do T-bar for grade 1 case. So we don't know how the grade 1 case will go on in the future. Do you have any experience about it?
Okay. Either for me, either grade 1, I always try to use the medical treatment first, and I try to follow up this patient 5 or 7 days after to have the trauma, and we check the CT scan again. Sometimes it's not good, but you should maybe you can to grade 2 or grade 3 choose the TBAC. But I follow up sometimes in my patient when I follow up this grade 1, sometimes after 1 week, 1 month or 6 months, maybe to the transit to normal out now. I think it's a grade 1 better. The medical treatment is not the TBAC.
就好像他的问题都把我做掉了，对吧？他的做下来好像处理两个人，不知道都怎么样，好像是可以的，不过应该大家都会做。好长。对啊。Okay. Later we will show ascending aorta case. Actually, we don't have that many blunt cases, but this is the only one we face ascending aorta blunt trauma case. Yeah, this case is a very young patient. And this patient combined many other major traumas such as ICH, intracranial hemorrhage, and the facial bone fracture. So we combine with trauma team to finish this case. Now, Dr. Tsai will show this case. Okay.
Hello everyone. I'm a resident of CVS, and today I will present the case of open repair of bronch LT injury over ascending aorta. This is a 19-year-old male denied any systemic disease, and he sent to our ER due to traffic accident. And he was a tow rider hit by a car. Initial loss of conscious, and at ER initial vital sign blood pressure is normal, but mild tachycardia with conscious disturbance, 3CS E1, V2, and 5. Physical examination shows normal pupil size and multiple laceration and abrasion over trunk and lips. And initial protocol chest X-ray, no specific finding. And we arranged advanced CT scan, including brain, abdominal, C-spine, facial, and chest CT. And his impression including traumatic SDH, ICH, and pneumostaphylase, liver laceration, and multiple bone fracture. And we focus on the chest CT finding. The chest CT shows sternal fracture and ascending aorta tear with pseudoannular formation. As you can see, this is a tear red, and this is pseudoannular formation. Concern about traumatic SAH and ICH, and with stable vital sign without aortic rupture, we decided to arrange surgery 10 days after conservative treatment of traumatic SLH and ICH. And the operation detail is about a traditional sternotomy. And the total bypass time is about 225 minutes. And the circulation arrest time is about 32 minutes. And we conversion over inaugural artery with 8 mm graft, and we use the conversion as also as integrate cerebral. And this is the operation finding. You can see the translation of LT intima. And he recovered smoothly and discharged under stable condition 3 weeks after the surgery. And this is CTA follow-up 6 months after the surgery, and you can see it's under stable condition. And thanks for.
Okay, for this case, we have some concern. Firstly, the case is a major trauma case, so we have to delay the open surgery after the stabilize of the intracranial hemorrhage. And the other problem is that the patient also has facial bone fracture. So for the airway safety, they do tracheostomy before our open surgery. Yeah, then they will limit our sternotomy wound. And the other concern is that this patient is very young, so his native aorta is very small. So we will construct this aorta with a very we construct the ascending aorta with 18 millimeter 18 millimeter graft. So this is much smaller than our normal ascending aorta replacement case. Actually, I don't know how. I don't know if it will impact any in its future. But the CT scan now still looks good now.
Okay.
Any experience about ascending aorta case?
Thank you for your presentation. It's great. In my center, it had only 2 cases. We had a problem with the ascending aorta, and at the same like you, I always try to control this bleeding from to another organ first, and after that you choose to the open repair with the replacement of the ascending aorta. But I think it's the same. We had the only choice for this patient. We had the ascending aorta. We had treatment by the open repair. And I have a question for you. In your operation, do you use a heparin? And so what do we use in heparin patient in your operation?
For this case, we still use normal heparin dose for regular aortic open surgery. Because we have to use Hala machine, and we have to do circulatory arrest. So we have to use the heparin dose is just normal.
In my center, sometimes you had trouble with the ascending aorta lesion. Sometimes you had the combine with the esophagus and chachio2, and some case you had a problem. You had infected after the surgery. We had a very difficult to control, and this patient maybe follow up and come back later with 1 or 2 years later. we had the trouble with the adrenaline. Maybe I think it's a native from to the ascending aorta because we not controlled enough for to the esophagus, and maybe we beat the lesion from the esophagus too. And what about your experience about it?
Do you ever try endovascular technique in ascending aorta?
For me, it's a time now, no. Only in the idea, not in clinical.
Okay,
for this patient, if sometimes for too young, I think it's a TVI is not the best choice for this patient.
Yeah. For the case you show your zone 0 case. So the policy is to do differentiation first and EVA later, right?
Right. Always I bypass first.
Yeah.
The total differentiation. After that, it puts a stammer.
Yes. For the bypass case, you replace the ascending aorta, or just differentiate the aorta, the ascending aorta or the native.
Yeah, for my case, only to the differentiation. It is not ascending replacement.
Oh, okay.
Because this lesson only to the zone 1.
Yeah. So you will do carotid bypass, right?
Yeah.
Yeah. So for the case, the carotid bypass, your graft will go through retro esophagus.
No, before. I will try to the before.
Oh, okay, I see.
Yeah, anterior. Yeah.
Which graft you will use for this carotid bypass?
The Duckrow with the
not that from graft. Okay.
Yeah, that's the one. In your hospital, is the TIVA is what done by CVS or what done by vascular surgeon or cardiac surgeon?
Yes. In Taiwan, the TIVA and the EVA case is performed by cardiovascular surgery.
Okay. Yeah. I had to 6-month training in the Taiwan in the National Taiwan University Hospital.
Oh yeah.
In the past, in the 10 years ago.
Yeah, Dr. Wu, right?
Yeah, with the Professor Wu.
Yeah, Professor Wu, yeah.
Yeah.
Very good. 啊？不是吴一回啊，很大的吴一回。Yeah. Oh, okay. So, thank you for your nice sharing.
Okay, thank you.
Yeah.
Thank you. I hope to see you again. I hope to see you soon. Yeah.
I will see you soon.
Okay.
Thank you.
Thank you.
Bye bye.
Bye.